All right, today we're going to demystify a condition that is, believe it or not, incredibly common, but it's so misunderstood that it can sometimes take years to get a proper diagnosis. We're talking about polycystic ovarian syndrome, or PCOS, and it really is a puzzle that affects millions and millions of women.
So let me ask you this. What do you think connects things like persistent acne, really irregular periods, and even struggles with fertility? I mean, on the surface, they seem like totally separate problems, right? But they often share one single hidden cause.
Yep, the answer is polycystic ovarian syndrome, PCOS for short. It's a really complex hormonal condition, and it affects women during their reproductive years. And, because the symptoms can look so different from one person to the next, it's often a genuine puzzle to figure out.
And just how common are we talking? Well, PCOS is actually the most common endocrine disorder in women of reproductive age. We're talking up to 16% of them. That's roughly 1 out of every 6. It hits women from all different backgrounds, and yet, get this, its fundamental cause? Still a mystery.
Okay, so to really get what's going on with PCOS, we have to kind of pop the hood and look at the engine. It all boils down to a fundamental hormone imbalance. So the main thing, the central feature of PCOS, is something called hyperandrogenism. I know it's a technical term, but all it really means is having too many androgens, what people often call male hormones, like testosterone. And this is what's behind many of the most visible symptoms, like stubborn acne or that excess hair growth, which has its own fancy name, hirsutism. So where are all these extra androgens even coming from? Well, the problem often kicks off right in the brain. Think of it like a conductor leading an orchestra, but their timing is just off. The brain is supposed to send out signals in a very specific rhythm, but with PCOS, that rhythm gets all jumbled up, and that completely messes with the balance of 2 really important hormones that are supposed to be following its lead, LH and FSH.
Because of this imbalance, the body starts making way too much of one hormone. That's luteinizing hormone, or LH, and not nearly enough of the other, follicle-stimulating hormone, or FSH. For about 60% of women with PCOS, this ratio gets totally out of whack. We're talking the level of LH can be more than double the level of FSH. That's a huge difference.
And that messed up ratio, it sets off a chain reaction. All that extra LH basically tells the ovaries, hey, make more androgens. At the very same time, the low levels of FSH mean the follicles inside the ovaries just can't mature the way they're supposed to. The end result, ovulation gets disrupted, or sometimes it just stops altogether. And that's why irregular periods are such a classic telltale sign of PCOS.
But wait, that's not the whole story. There's another huge piece of this puzzle, insulin resistance. Basically, it means the body cells just don't listen to insulin properly. And here's something that's really important to understand. This is not just an issue for women who are overweight. Women with PCOS, whether they're lean or obese, are almost always more insulin resistant than women who don't have the condition.
So, to try and make up for this resistance, what does the body do? It goes into overdrive, just pumping out more and more insulin. And here's the real kicker. All that extra insulin floating around, it also signals the ovaries to produce, you guessed it, even more androgens. This creates this powerful, vicious cycle that just keeps feeding itself, making the whole situation worse and worse.
Okay, so with this incredibly complex web of hormones all tangled up, how on earth do doctors actually diagnose PCOS? Well, it really is like being a detective. It's all about connecting the dots.
There's an official guide they use, and it's called the Rotterdam Criteria. It's pretty straightforward. To get a diagnosis, you have to check at least 2 of these 3 boxes. So, number 1, having irregular periods, which points to irregular or no ovulation. Number 2, showing clear signs of high androgens, either things the doctor can see or what shows up in your blood work. And number 3, having what are called polycystic ovaries that a doctor can see on an ultrasound.
But, and this is a really, really important point, PCOS is what's called a diagnosis of exclusion. What does that mean? It means before a doctor can say for sure that it's PCOS, they have to rule out everything else that could be causing similar symptoms. We're talking things like thyroid problems, certain adrenal disorders. They have to make sure it's not one of those first.
Now, it's really easy to hear all this and think of PCOS as just being about periods or acne, a reproductive or cosmetic thing, but its impact goes so much deeper than that. There are some serious long-term health implications we have to talk about.
See, because of that underlying insulin resistance and all the hormone imbalances we talked about, PCOS seriously increases the risk for a whole bunch of other health problems. And I'm talking about big stuff like type 2 diabetes, heart disease, unhealthy cholesterol levels, even certain types of cancer and complications during pregnancy.
Let's actually put some numbers on this so you can see how serious it is. There's something called metabolic syndrome. It's this dangerous mix of high blood pressure, high blood sugar, and bad cholesterol. Well, in women with PCOS, the rate of this syndrome is a staggering 45%. Now get this, that's more than 10 times higher than the rate you see in women who don't have PCOS. Just wow.
And the risk to your heart? It's also dramatically higher. One study predicted that women with PCOS face a risk of having a heart attack that is 7.4 times higher than women without the condition. That's a huge number.
There's also a cancer risk to consider. See, because ovulation isn't happening on a regular schedule, the lining of the uterus gets exposed to a lot of the hormone estrogen, but without that usual balancing act from progesterone. This situation is called unopposed estrogen, and it can increase the risk of endometrial cancer by up to 3 times. Okay, I know hearing all of that can sound pretty daunting, but here's the good news. PCOS is absolutely manageable. The real key, though, is understanding that there is no one-size-fits-all pill or solution. Treatment has to be completely personalized to you.
And that treatment strategy, it really depends 100% on what a person's individual goals are at that moment. For example, if someone isn't trying to get pregnant, the focus is probably going to be on managing symptoms, getting periods regular, tackling the acne and hair growth. But if the goal is pregnancy, then the entire game plan shifts to focus on one thing, inducing ovulation.
And luckily, the toolkit for managing PCOS is pretty broad. Lifestyle changes are always the foundation. I mean, even a 5% loss in body weight can sometimes be enough to restore ovulation just by improving insulin sensitivity. Then you have things like hormonal contraceptives. They're usually the first-line therapy for regulating cycles and bringing those androgen levels down. To tackle the metabolic side of things, doctors often use insulin-sensitizing drugs like metformin. And for very specific symptoms, like hirsutism, there are anti-androgen medications like spironolactone that can be really effective.
And that kind of brings us to our final thought here. PCOS isn't just one single disease. It's a complex syndrome, which means it has many different faces, and there's probably a genetic link in there somewhere. So the big question looking to the future is this. How will research help us move beyond just a single, catch-all diagnosis and start creating truly personalized treatments that fit every single individual dealing with this complicated puzzle?